Annual Dialysis Conference, presented by the Carl Nolf, MD, Division of Nephrology.
As you all saw, the topic for today is retaining patients on home dialysis. And the objectives of our talk or discussion today would be to understand the challenges in home dialysis patient retention, why patients leave home dialysis, explore the roles of our multidisciplinary team members, and review case studies that have demonstrated successful intervention and kept patients at home. So we'll have 3 cases to discuss today. So I wanted to start off with looking at home dialysis utilization rates. So this is the annual data report from the ESRD database. So this looked at data going back from 2012 to 2022. And as you can see here, the home dialysis patient population increased from around 8.5% in 2012 to about 14.5%. So this is again over a 10-year period. But what's interesting is that this was mainly driven by growth in PD population. So again, if you look at the y-axis, these percentage points are separated by 10 points each. This is important because the next slide, which is the home hemo utilization, is on the y-axis, it's just separated by 1 percentage point. So as you can see, home hemodialysis utilization is much lower compared to PD. So whatever growth that we have seen in the last decade is mainly driven by increase in our PD patients. And if you want to look at like absolute percentages, the percentage of patients that started home hemo in 2022 was a mere 0.4%. So very, very tiny percentage. So there has been some growth in our home dialysis population, and mostly driven by PD, very little home hemo. But we also know that there is a significant percentage of this population that will switch to in-center hemodialysis within 2 years of dialysis initiation. And I just put this information in a couple of polls. So if our participants want to just put the answers in the chat box, what they think is the right answer. So based on the 2024 ESRD annual data report, and this is for the 2022 data. So what percentage of PD patients that initiated dialysis in the 2020-2021 year switched to in-center hemodialysis within 2 years? Is it 46%? Is it 32%, 16%, or 70%? So I'll give it a minute there. So I see A, 46%, and another answer is 70%. So the actual answer here is 32%. So I know those numbers are a little bit closer. So maybe I should have made it like, more stark or whatever. But the correct answer is B. And this is demonstrated in this graph. As you can see, the PD to ICHD conversion, this again going back to different cohorts. So you have the cohorts from 2012 to 2013, going up to 2020 to 2021. And this is going to be the same trend that you'll see in home hemo as well, that the cohort that started PD in 2020, 2021 had a higher rate of conversion compared to the cohorts that started earlier. So next question, based on the 2024 ESRD annual data report, again, the same data, what percentage of home hemo patients that initiated dialysis in 2020, 2021 switched to in-center hemo within 2 years? So again, put your choices in the chat if you can. So D, 66%. So I see a C. Okay. So the correct answer is A, 38%. So this is the graph again from the ESRD data. So the cohort that started home hemo in 2020 to 2021 had a higher rate of conversion compared to the earlier cohorts. So Almost like 35 to 40%. So higher rates with home hemodialysis. There is a big conversion from these home modalities to in-center home, dialysis. So what are the reasons for loss from home dialysis? So there are a variety of reasons. It could be a lack of support at home. So we see this quite frequently when patients start dialysis. There may be a support person at home. It may be a family member, a spouse, or a friend, or whoever it may be, and their situation may change. Maybe that person that was their support may have moved away or passed on, or whatever it may be. That is a very, very common reason that we see. Fear and anxiety of managing dialysis at home. So maybe somebody does have support at home, but it's hard for people sometimes, or a lot of times, right? Especially if it's a loved one, if you are taking on a responsibility of like doing the treatments day in and day out, you do have to take the responsibility of what if I do something wrong. So there is a lot of that going on, and I think one of the cases that we will be presenting later had that situation come up. So the support people do have that fear of like, what if something bad happens and I don't want to be living with that guilt or whatever it is, right? So that is a major issue as well. Complications or hospitalizations. So sometimes patients get hospitalized. Their ability to do dialysis on their own is gone, so they are no longer able to do that at home. So that is also a very common reason. Psychological barriers and burnout. And again, this happens more often, especially if there is a support person that has been the main one doing all the dialysis, and eventually they get burnt out. So we do usually, want the patient to take on the chunk of their the care responsibility to themselves, and then keep the family member or a friend as a support person rather than putting all the burden on them. Obviously, a patient can get burnt out as well, so it would help to have some sort of a respite type of care available for those situations. Inadequate training or follow-up. So if there is no proper training, again, Kim can talk to this as well. When they go on and do the home visits, it's important to know what their home conditions are like. Do they have appropriate, infrastructure in place or not? Are they being trained for like infection practices properly or not? Because these, if they don't do well with all those, things, they can lead to infections or other things, and that can lead to loss of patients to in-center dialysis. And some patients just, prefer to do in-center care, because I have had a few patients that, did home dialysis and they just didn't want to do that anymore because they found that social connection in doing in-center dialysis, and by being at home, they lose that. So there are patients that do decide they want to do in-center dialysis just for that, social connection even. And also, obviously, there are people that are like, I just want somebody professional. I have heard that from patients when they say, I just want somebody that is professionally trained to do that for me. And I don't want to do that. So what does it take for patients to stay home, and what does it take for us to keep them home? We need a really good multidisciplinary team. So it takes a village to support our dialysis patients at home and keep them home. So these are the team members. Nephrologist has the clinical oversight and patient selection. But I think the most important team members are the nurse, the social worker, dietitian, because if, they can make or break the situation. And if you have a very supportive team, you can do a lot of things out of the box even, and keep the patients at home. So the nurse obviously provides education, training, and monitoring. Social worker, and we reach out to our social worker quite a bit, because a lot of the situations that have come up in the cases that we'll discuss required a lot of social worker interventions. So dietitian has to provide the nutritional guidance and support. And at least one of the cases that we'll be presenting, the patient had a lot of nutritional needs that were adequately taken care of with the dietitian support. And finally, the technician is going to have to help with equipment setup and troubleshooting when something does come up. So with that, we will move on to our 3 case studies. So our first case is going to be a patient that started dialysis fairly young, at a young age, and she has had frequent hospitalizations, but we were able to retain her at home through a lot of coordinated care and home visits. A second patient that had a really big fear of needles, was not able to do PD because of bad infection that had to transition to home hemo. The team was able to provide a lot of support and ongoing training and respite care. And that patient was able to stay on dialysis and eventually was able to get a transplant. Finally, our third case will focus on somebody, an older patient that had a lot of rehab needs. Nursing home could not provide PD. So we were able to support that patient until he went home and is doing well. So with that, I will have Kim jump in and start presenting.
Our first case study that we were talking about was a young lady that had started dialysis at a very young age. She had gone through basically all the different modalities. She had started out with PD, had multiple issues being young and things like that, had infections to where it wasn't really an option for PD any longer, moved to in-center, and then actually ended up with severe hypertension causing a stroke that was fairly debilitating for her. So she ended up with some pretty severe deficits that required a lot of full care. And so at the time that we were looking at the options for if she could be discharged out of a long-term care facility to be able to return home to her family. So what we were asked to do is kind of evaluate the possibility of home hemodialysis as PD was no longer an option. So it did take a lot of interdisciplinary interaction. So it took evaluating the home. It took evaluating if transportation was an option. So she had a lot of needs that were needed to be fulfilled. She had a trach. She wasn't really initially swallowing at the time, so nutrition was an issue. She still was dealing with hypertension issues, of course, mobility constraints. So there was a lot of underlying needs that she had. So it took an entire team to decide, yes, we can do this, or yes, no, we cannot. And so the first steps were really evaluating it as a team to see if we could take this on. And so steps with the social worker was coordinating transportation to make sure we had the equipment for her mobility at home, make sure that she had the home support for hospital beds, things that she needed to be able to support her on a home hemodialysis option. And then, of course, the emotional support of can the family take this on? Can they offer the support and the needs that she had? So when we started out evaluating, RN went out to the long-term care facility to speak with the mother, see the patient, evaluate, went to the home to evaluate. So it took a lot of steps within the whole entire group to kind of come to terms that we were going to try to make this happen so that she could go home with her family. And of course, with the nutritional needs and things, she, really wasn't able to eat much nutrition. So there was tube feedings and things like that. So all of that had to be kind of arranged and make sure that we had the appropriate tube feeds for dialysis needs and everything. So it took the whole team, but we did finally get them fully trained. The mother was able to coordinate coming with her to dialysis. And the biggest transportation need was they lived quite a ways from the facility. So there was a lot of transporting, getting her here, keeping them here long enough to get everything done, and then making sure they were set up at home thereafter. So the patient was able to successfully go home with her family, and she spent her last 8 months at home on home hemodialysis without having to live in that long-term care facility. So it was a big underlying challenge, but we did find ways around it to assist them. Mom took on all the care at home and was very successful with that. So it was a success story, even though it took the whole team and many challenges to face to kind of get that to happen. So that one was a positive for us for sure.
Yeah, and I think like you said, the mom was the main person that was taking all of this on, but also I think the dialysis unit staff, all the nursing staff, they had a lot of, input and a lot of help and support that they had to provide for this to be successful. And I think there were also times when she came in for some respite care, right? Or
not too much for respite care, but they had issues along the way that they would have to come back in, and we would have to provide extra assistance and things like that. So it did take a lot of follow-up and just a lot of over-the-phone interventions and assistance to help mom kind of stay on board with the correct path. So, but it did took the whole team for sure. It was very involved across the board.
Yeah, definitely. Ankur, Kunal, Osama, do you have any similar experiences or anything you want to share about, any patients like this that you've dealt with?
So, Kunal here. Thanks, Kim. It's great to hear your voice after working with you for over 12 years.
Yes, it's good
Miss
to hear
you and your team. I am currently dealing with similar situation. I have a young gentleman. He has progressive CKD. He's having challenges. He's wheelchair bound, and his mom is the primary caregiver for him. And he was stage 5 CKD has been for over 5 years, but now he started developing uremic symptoms, has frequent UTIs, has an indwelling catheter, I think maybe suprapubic catheter, but frequent UTIs. So, he has gotten access. He has got a fistula. It's working good. But right now he's admitted right now in another hospital in the city for a UTI, but his numbers are stable. He's not needing urgent dialysis. So right now we are waiting for him to transition to home. The also challenges, he lives across the river in Illinois side. I'm in Missouri side. So trying to coordinate care with our home dialysis team on how to get the parents trained on it. And so this was a good motivation for me to, keep working and having patience and not give up, because we have to just find a solution that works. Mm-hmm. But the team is engaged. Everything is lined up. We have to just the family is very busy. The patient is all right now in the hospital. So hopefully it will work out. And, for training, they have to come a long way here every day to get trained. But I think once the training is done, it should, go on smoothly. I hope so.
Yeah, absolutely. It does take a lot of, engagement for sure, and support from the dialysis unit. And we've been very fortunate, Kunal, as you know, we have a very, wonderful, amazing home dialysis team here. So very fortunate. All right. Let me move the slide.
Okay, our second case study we have was a young man who started, again, very young on dialysis, had a lot of family support, had again started on PD, and again, unable to continue on PD. Did get a transplant prior to this, and then had complications requiring him to go to in-center hemodialysis. And as a young man, obviously this was not his ideal option. And so we started pursuing the option for home hemodialysis with him. And he had the support of his mom was his main support, but his whole family was very involved with his care. His biggest concern with not being able to go back to PD and wanting to go home was the challenge of having an access. He had a severe needle phobia. He just had big complications with making that happen. And so our biggest concern was getting him home with an adequate access that was less infection risk. And the mom was on board with, I think, doing a lot of it, but we urged him to take on that challenge. We urged him to try for creation of buttonholes. And so we did the complete training, got them fully comfortable. The mother was his care partner in doing the setups and helping him with all the treatment process and everything. But it took us an extended amount of training with the use of even our in-center HD support to get him slowly transitioned to using the needles. And so we just kind of took our time. Some days it would be a half hour before we could get him to put that needle up to his skin to even begin the cannulation process. So it was very slow for him, but over time he got more comfortable. We worked with him as we trained on our home hemo process, but then he needed longer and more time. And so we were able to use our in-center to have our home nurse go over there during the cannulation process and work with him on continued training until he was able to feel confident to do that. And so it was nice to be able to have that ability to do the long-term training. And he was able to create his own buttonholes. He actually created 2 sets of buttonholes over time and was successful on home hemo until he was able to get another transplant. So he did very well. And again, patience is the issue with them and trying to get them over some of their fears and anxiety. And, mom had helped him as a kid on PD as well. So she was very supportive. However, I think she was also wanting to encourage him to take on some of those roles on his own, which he was able to successfully do over time. So again, another success story. Most of these are all success stories, but these were challenging ones, especially as they started at a very young age and needed that additional support from family.
Yeah, and I remember, I think it's one of the patients that had a longer training period compared to our usual expected time. But I think that's what it takes, to meet the patient where they are and get them comfortable. But this patient, because of his previous transplant, had high antibody levels and was having trouble getting offers for a second transplant. So even though he was pretty healthy and young, he had to wait a long time to get another transplant. But fortunately, he was able to maintain on this modality for the rest of the time until he got the transplant. Kunal?
Yeah, I mean, what stands out for me in this case is, buttonholes have got a bad rep recently over last few years. But, if it works for a patient, that's more important. Like, the bad rep they have, the infection risk, that's a slightly high risk, but in the patient who's engaged, who watches it, takes care of it, I think this highlights, like, it's not a contraindication. It's not like they are the worst evil access or whatnot.
Great point, Kunal.
And another thing with him is, as we transitioned into using those, is we did have to start out using an agent to numb the area and things like that. And we were able to, with the buttonholes, able to move away from that. I think we used Emla cream for him initially, which we tried to avoid the lidocaine, of course, but he was able to slowly move away from that as a need.
Mm-hmm. Osama?
Yeah, I just want to give another shout out to the buttonholes. I think, when we look at the literature, yes, the data that is currently available shows that buttonholes have increased infection rates compared to other cannulation techniques. But if you compare the infection rates with buttonholes to things like tunnel dialysis catheters, the buttonhole infection rates are, if I remember correctly, 1/5 or 1/6 the amount of tunnel dialysis catheters. So yeah, they get a bad rep, but honestly, I think it's overplayed, and a lot of it is dependent on just following the technique. And I wish Maria was here because she's the buttonhole queen.
I know.
But yeah, buttonholes really do work, and I like them for my home hemodialysis patients.
Yeah, and our patient never had an infection, so over the 4-year period that he was on home hemo. So
on that note, Preethi, wasn't buttonhole invented by Dr. Twardowski?
Yes, at MU. So that's Ankur?
I am also team buttonhole, but I will also put out a word for the much maligned catheter. And the word that I'll put out is that if we're being patient-centered, they're like, it's amazing to get through this level of needle phobia, but not everyone will, and also not everyone is 13 or 25 when you're dealing with them. Some patients, the best access for them is a catheter, and we need to move our view from one that is very much about standardization to one that's a little bit more about autonomy. By forcing every patient into our access of choice, we are kind of impacting our patients' autonomy to choose their own access. And also put in a word for the next webinar, because we'll be talking about vascular access and catheters at home. So to be continued.
Yes, for sure. I mean, instead of fistula first, it should be like patient first, whatever, patient choice first, I guess.
I love that.
Yeah.
Patient first instead of fistula first. I will be stealing that.
All right, so let's move on to our next case.
Okay, so case study number 3, we're dealing with a different age group. So this was an elderly gentleman. He's 82 years old. When he started out with when he hit the need for starting dialysis, he was already at the phase with heart failure, that it was felt that hemodialysis was really not the best option for him. And so a PD catheter was placed with the challenges of then having the need for rehab, quite extensive rehab for quite a while. And so once he was released from the hospital, we worked with the facility for his rehab. So it was a skilled facility. We worked with the patient and his wife to kind of coordinate him being able to remain at rehab. And this facility was not trained on peritoneal dialysis, and they did not wish to be trained in order to do that. So we were able to coordinate transportation from the facility to our facility 3 days a week to do in-center peritoneal dialysis. So we were able to offer the support to continue to give him home care or PD in order to still have him be able to receive the rehab he was needing. And then during that process, as we got closer to the ability for him to go home, we were able to bring the wife in during his treatments and do training with her to be able to build that comfort level of going home. One of the things that Dr. Yerram had spoke earlier about was the fear and the anxiety of a caregiver taking on this role. So at this time, he was pretty ill. He was a very sick gentleman. And so she had a lot of fear. She had a lot of anxiety about taking him home and being responsible for not only the PD, but all the other aspects of his care. And so it was a big challenge to get her comfortable. So it was an extended training through the process of the rehab and kind of thereafter, just to get her ready to go home and get him to the point where he was able to physically go home as well as comfortable with doing the dialysis at home. And so the team support was across the board, social work needs of emotional support. We had to work with transportation to make sure we could get him to and from. And he also, being as sick as he was at that point, needed a lot of nutritional support too. So besides the nurse that did awesome with all of the training and being there every single day to do that dialysis, because at that point they had a lot of needs. And so it took the entire team to make this happen. He did successfully finish training and they went home, and he is thriving now. And so in order to get him back home where he was wanting to be and be home with his wife, that was the big win, is to be able to make that happen.
And I think the interesting thing with this situation was that our unit is certified for in-center PD, right? And that's, I'm not sure if that's a state-specific certification, right? And the rules may be different in different states. I'm not sure. Ankur or Osama, do you know?
I think a lot of places don't realize that you need an independent certification for in-center PD. I'm pretty sure that is a national requirement. And I do think that particularly with respite care, sometimes we don't realize that that is something that we need, and something I would advocate for every PD unit, because that is, of course, how we provide respite. So yeah, it is something that I think we all need, but don't necessarily all have.
And sometimes it's like to piggyback on what Ankur is saying, it's a matter of your dialysis unit just checking that box, right, when they're initially getting their certification. So, for example, in our in-center dialysis unit, I started a self-cannulation initiative, and then that's when I had to check to make sure that our unit actually is approved for self-care, which is just another box that they would check off.
Okay.
Yeah.
Okay. All right. Okay, that's the end of our cases. And we'll talk a little bit about multi-pronged interventions.
Do you want to go through these, Dr. Yerram, or you would like me to, or?
Yeah, go ahead.
Well, so some of these are just kind of overall, some of the basic things that as a home dialysis or as a PD unit or home hemo that it just takes to even get the patients kind of to this stage where they can go on a home option or they can sustain it. And so one of the areas, a lot of social work involvement is the home environment and the nurse evaluation of the home environment. So we've had cases where we've had issues with patients maintaining their home and environment because of inability to pay or inability to keep up with housekeeping, or they may have pests and things like that. And so we have gotten access to assistance in, having the home sprayed for bugs, or we've had minor repairs on the house that maybe have to have done, and we've gotten financial support to help them with that. We've had a home hemo patient that had no actual bed or recliner chair, and we were able to get assistance to get those in the home as well. And so sometimes just getting those environments ready is one big step to get them onto the therapy or to maintain that.
Tim, you want to talk a little bit about what kind of resources were used to pay for those kind of improvements for the patients?
So our social worker works a lot with the local assistance. Like they have the Kidney Foundation. They will offer so much support for patients that meet the needs. And so sometimes they have to show that they have the need for that, but they'll help in small home repairs. They'll help if they get their electric turned off, things like that, to offer assistance. And they were the ones that helped us get a chair or a bed for the patient when they were needing, and that. But there's other things that can kind of help. And they actually, we had issue with pests in the past, and they helped even pay a portion of getting the home sprayed and keeping it safe and clean as well. And then of course, Medicaid can help somewhat with getting assistance into the home as well, to offer housekeeping or just upkeep, or coming in and helping the patient to be able to get in and out of the bathtub or the shower and things like that. So really, it's the best thing is just to look at your local options, and we have flyers up in the lobby area for patients to find assistance and things like that, because sometimes even churches and organizations and things will offer support as well.
Yeah, and I think the social workers do a great job of procuring those local resources. But Missouri is also one of the states where there is a state-funded kidney program. So the Missouri Kidney Program, they also are able to help. They have some grants. It may not have necessarily used that for this situation, but if your state has a kidney program, they may be able to help as well. And I think AAKP has some grants. So there are a lot of patient organizations that are able to help as well.
And that kind of ties in, Dr. Yerram, with the health equity. That's one thing that they've really started looking into as well. is like nutritional needs and housing and utilities, transportation, financial support, safety needs, things like that. Those organizations can help a lot with those items as well, just to help offer additional support. And then one of the things that with the health equity is putting together a plan within your unit to offer what available resources are in the area. And so like our area covers a pretty wide span of Missouri. And so we have a booklet that has all of those different options in several areas within Missouri. So another area would be the burnout support. So we kind of talked about this a little bit with the available option for like in-center PD would be an option. So, patient's family that takes care of them may be traveling or maybe out of town or maybe sick themselves. We have a TCU unit here, and that offers the ability for patients to also come in and run on in-center hemodialysis if they need to, just to take some relief off of them at home, or say they have an issue that's going on that they can't do home temporarily, then it gives them a backup support system. It also gives us the opportunity, like one of those case studies is to prolong that training in the in-center side, even to offer further cannulation practice, training on the basics and things like that, just to give them that little bit of backup support. Another area that we cover as well is pediatric care. And so that multidisciplinary support is a big factor in pediatric care, just not only the start of dialysis, but the support and the emotional changes that patients go through, family goes through, offering them that information of how things are and how it works and everything is a big factor. Of course, nutritional needs are going to be different with pediatric patients because they're still growing. We want them to continue to grow. So we want to offer them the support they need to make sure that nutritional need is met. And of course, getting the family here and comfortable and trained and trying to include those pediatric patients. So a lot of them are teenagers. And so getting them involved and helping support them to kind of take over some of that self-care is a big thing too. And then it takes a lot of follow-up support with the kids and the pediatric coverage as well. Let's see. Some of the other needs that we find with our patients are mobility, visual issues, dexterity, and then learning needs as well. So there are oftentimes assistive devices that we can use with patients. So in the past, we've had patients that have had strokes and had, deficits on one side of their body. So having two hands to connect their PD catheter or to put their cap on or just to hook themselves up and open the clamp. There's devices that offer assistance for them to do it one-handed. And so it may take a little longer to get them comfortable with the assistive aid, but it's something that they can still learn to do on their own. And then, of course, adjusting training processes to fit each individual's needs. So patients that maybe don't read as well, or the understanding is a little bit different, finding those things that help them. So visual aids, we often use videos or pictures. One of the big things that we do here is we use flip cards. And so patients that get off track reading through instructions or sets of instructions, we separate them out and let them flip the cards. And we've even done just picture charts so they kind of follow those steps. Post-hospitalization care, that's a big factor in sustaining care and the longevity of them being able to stay on a home therapy. So follow-up after hospitalization, assisting with outpatient rehab like we've done in the past, follow-up care soon after the hospitalization. So we make sure that we don't have any retraining needs or medication changes that need to be adjusted. And then just following up that we don't need to bring them back and reevaluate if they've had a long-term hospitalization. And then the last thing here is the infection recovery and prevention. So As we all know, infection is one of our big challenges in sustaining home therapies. And so making sure that we're constantly doing reevaluations and retraining and technique reviews routinely to make sure that the patients are hopefully avoiding those infections and that they're learning how to evaluate for those so that we can, make sure that we offer the support they need to get over it quickly.
So with that, I think just to summarize, we know that retention of home patients requires a team-based approach, as Kim has talked, a lot about the interdisciplinary approach that it takes. And it requires addressing medical, psychosocial, and logistical barriers, as we have seen, and with a lot of collaboration among team members that will lead to better outcomes and keeping our patients home.